for the last time talking about my family situation. And today I want to just come and talk about some of the recommendations that I have. And first start by saying thank you for you guys incorporating me into the process. It's like a zooming speedy process, and you guys are trying to accomplish a lot, and I want to offer myself as someone who has 17 years of experience in working with children who were CPS adoption placements, who have been high needs and have had every intervention that I've been able to offer and still have struggled. And as of this week, my daughter is getting another neurological evaluation to figure out why is she not able to socially learn and to control herself. So I wanted to say there were a number of things here today that I endorse. I'm glad to see that are in your recommendations. Assessing the adequacy of the mental health network, wow, it's a really big one that was mentioned, and yes, because that's one of the things I wanted to talk about. Second is this coordinated care model. Absolutely. At one point I had 16 mental health providers that I was working with, and every single time I go to a new treatment center I have to fill out the same form and access the same information and drag it up and re-traumatize myself, as Kristen was saying, even at the insurance appeal level. Really difficult to justify why I wasn't able to deliver what my children needed at home. Also, the annual screenings as part of well-child visits, whether that's in the primary caregiver, the doctor's office, or in the school, I don't know which is best, but absolutely there needs to be annual screening. And then having mental health services as part of the definition of basic education funding. Yes. I mean, I had to bring a lawyer in to prove that my child's behavioral problems were related to his neurological problems in the special ed system. And I just see the need for that enormously. So what I want to talk about today, trying to be quick, and I'll just read most of this, is to keep myself organized, that the age of consent in this state gives minor children who are only halfway to developing adult brains at the age of 25, adult choices that they will live with for the rest of their lives. And I want to acknowledge that there's been multiple attempts over the years to try to address some of the unintended consequences of this well-intentioned act to give children who are sexually active access to reproductive services. And I would not want to eliminate that at all. And I wouldn't want to eliminate children's ability to opt in to treatment. They must have their privacy maintained should they wish to have an abortion, for example. However, what we are doing now is excluding parents from the process, and yet parents in the state are financially liable for the harm that their children over the age of 13 cause. We have the right to determine through divorce custody where our minor children reside, but we're not able to determine that long-term residential treatment is appropriate without our child's cooperation. And effective treatment for adolescents doesn't use an identified patient model. Instead, evidence-based practices treat the whole family system. And with the 100 or so families that I've encountered in the inpatient treatment system out of state, all of which are private pay, all of which are families that supposedly have resources and families that are supposedly healthy, all these families have had major issues that have required family therapy that to be as intensively involved as the children. So the issue isn't just access to treatment, it's also effective involvement in treatment. So without full disclosure and collaboration between the therapist and parent, the child's best interests are not protected. So while we have things like parent-initiated treatment, that doesn't mean that a child is going to give the parent the right to participate in treatment. Children whose behavioral symptoms put them at risk should not be able to opt out of having their family involved in treatment. These are medical conditions, neurologically based, and we treat them as if they are character flaws or something as a discipline problem. But I just want to list some of these things that we really need to take seriously as issues that mean that children at 13 years old are being put at risk, and we're just sort of washing our hands of them so that they could get reproductive services. High impulsivity, refusal to follow therapeutic assignments, psychosis, self-harm, substance or process abuse, criminal behavior, fire setting, insecure or reactive attachment, inappropriate online sexual activity, physical and violence, requiring police involvement, failure to follow safety commands, runaway attempts, school suspensions or other disciplinary action, school refusal, school failure, severe oppositional defiant behaviors, and other high-risk behaviors. And I know that list because that's the list that I've been dealing with, and this is the list that I've been faced with trying to help my children in Washington State, where I'm not allowed to be involved because my children have said, I don't want you involved. So our available interventions: parent-initiated treatment, at-risk youth petitions, CHINS, CLIP, emergency room, juvenile detention, are all extremely limited in helping parents secure treatment for their children in a state that doesn't have any long-term treatment options available. Parents frequently do not even know these options are available. I certainly didn't know that parent-initiated treatment was available, wasn't informed of my rights to do that, and I was one of those families that you're talking about, that at the end, the worst, and still insurance is denying that my children had medically necessary reasons for treatment. Parents, navigating the system is cumbersome. Parents feel disenfranchised, shamed, and powerless to help their struggling children. And these are, I know so many parents that are really trying, and we are undermining and cutting them off at their knees to be able to be providing effective parenting. And I honestly don't think the state wants to take on parenting all these children. We've got a system devised for the families that are dysfunctional, and then we're not supporting the families that are functional. And we need to shift our thinking about that. So I thought about what could I bring to this group in the timing that you guys have. So I brought a recommendation about medical guardianship for parents of at-risk youth, and I wrote it out using Ashley's form. And I know that it's probably not something that we have time to discuss here, but I would really like to recommend that we employ a consumer-focused lens to examine the efficacy of existing mechanisms for parent-caregiver involvement in youth behavioral health treatment, and use that data to develop policies and procedures that update and modernize our system to make it more effective, increase access to treatment, incorporate best practices in how our behavioral health system serves at-risk youth and their families. And I'm happy to give you that language. Great. So you don't have to rewrite it. So thank you so much, and I just want to continue to offer any of my experience to help this really good group of people figure this out, because my kids have so many issues and I've got so much experience in it, and I don't see other parents who are capable even of getting here. It's only because I'm extraordinarily blessed to have parents who are helping me at 57 years old. My parents are helping me do this, so I want to help you.
Thank you, Penny, so much for coming again today and for all your insight and bringing up these important issues. And we're also, Kevin from the Senate committee's been doing some research around the age of consent around 13, and so we'll also have some more information for our work group shortly that we can look at that will give us a little bit more of a context around your recommendation as well. So thank you.
Thanks,
Kevin.
Thank you.